Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Dengue fever and other mosquito-borne diseases are spreading to new parts of the world thanks to climate change. Today, Stephanie Desmond talks to Dr. Anna Durbin, a vaccine expert at Johns Hopkins, about why these diseases are gaining so much ground, the public health emergency declared in Puerto Rico, and what tools are in the pipeline to prevent greater spread. Let's listen.
Anna Durbin, thanks so much for joining me.
Oh, it's my pleasure, as always, Stephanie.
So today I want to talk about dengue, and it feels like it's all over the news. So first, let's start with, what is dengue?
Right. Well, it's so interesting because we hear dengue and we think in the singular, but it's really four different dengue viruses causing dengue disease. So the dengue viruses are transmitted by mosquitoes. So it's a mosquito-borne illness that's really prevalent in all tropical and subtropical regions of the world. So think Latin America, the Caribbean, Asia, Southeast Asia. And it really is a disease that seems to just be spreading more rapidly. Certainly, we're seeing more cases this year and last year than we've seen in a very long time.
And I understand that one thing about dengue is that it gets worse when you get it a second time. You're the one who taught me that years ago. So talk to us a little about the symptoms and how that works.
Sure. So I always refer to them sort of as cousins or siblings. So they're related viruses. There's dengue 1, 2, 3, and 4. And what's interesting is if you get infected with one dengue virus, and I'll say dengue 1 for simplicity, and then you're subsequently infected with a second different dengue virus, that second infection can be more severe. And that's because the immune response your body makes to that first infection can help that second virus get into the cells that dengue likes to get into and replicate. So you get more virus and more symptoms. So typically about 75% of dengue infections don't present for clinical care. That doesn't mean they're asymptomatic, but it means people aren't sick enough to go see a doctor or clinician. And those symptoms can be fever, rash, muscle joint aches or pains. With more severe dengue, those symptoms are the fever can last for longer. You can have very low platelet count, which can lead to bleeding. And then in the most severe forms, we have something called vascular leak syndrome. And that's essentially where the plasma that's in your circulation, that's circulating in your blood, leaks out of, I'll just say your blood vessels. The fluid leaks out and it goes around your lungs. It can go into your abdomen. So you can't support a blood pressure. You go into essentially shock. And right now we don't have any antiviral agents to treat dengue. So we say that the care is supportive, meaning we will give you fluids to support your blood pressure. We'll give you analgesics for your muscle and joint aches and pains, and we'll try to support you through the course of your illness.
So I heard recently that Puerto Rico declared a pandemic of dengue, and that feels really close to home. Are we going to see cases in the mainland U.S.?
So we do have cases really every year in the mainland, particularly Florida and Texas. They're not well advertised, probably for tourist reasons, but they are present. The concern is that if there's a big increase in the vector, which is mosquito, Aedes aegypti, Aedes albopictus mosquitoes, which we have in the United States. We have Aedes albopictus here in Maryland, the Asian tiger mosquito that can transmit dengue. If we have, for instance, the right conditions, the right temperature, the right density of mosquitoes, we certainly can see more cases, particularly in homes, for instance, that don't use air conditioning, that don't have screens. And so in Puerto Rico, I think with different El Nino has contributed to this by bringing conditions that favor both the mosquito and the virus. And there's a lot of homes that don't necessarily have air conditioning. So people have open windows, open doors, mosquitoes can get in, and that's where we see more and more cases. And the concern is that, yes, we will see what we call autochthonous transmission, meaning that somebody, for instance, in Florida is bitten by a mosquito in Florida and transmit it to another person in Florida or Mexico, and that those cases will increase over time with global warming and things like that. So there is concern that we will see more and more cases in the continental United States.
How do we prevent this?
So right now in the United States, our only means of prevention is mosquito prevention. So you want to wear long sleeve shirts, long pants, wear mosquito repellent with DEET. Now, as everybody probably knows, it's difficult to maintain that every single day. And long pants and long shirts sometimes aren't comfortable in the very warm weather. But we don't have, the only vaccine we have licensed for use in the United States is the Dengue vaccine, which was the first dengue vaccine that was licensed. But it's licensed only for people 6 to 45 in the United States. And you have to have already had dengue, meaning that you have to test the person to make sure that they have had dengue before you can give it. And it requires 3 doses given over the course of a year. So uptake in Puerto Rico has been not very good. And in fact, there's some evidence that the company may stop making the vaccine because uptake globally has not been very good. So we really here in the US don't have a lot of options in terms of vaccine protection against dengue.
Why is uptake so low?
Uptake is low because Dengue has a storied history, shall I say. So when it was first recommended, we knew that it didn't work very well in people who had never had dengue before. But in the phase 3 clinical trial, there was a safety signal in kids who were 2 to 5 years of age. And that comes back to the age groups that the vaccine was recommended for, being 6 and older. Kids who were 2 to 5 years of age at the time of vaccination had a 7.4-fold increased risk of hospitalization with dengue 3 years after they were vaccinated. So the vaccine seemed to induce a higher risk of hospitalization for dengue 2 years after the last vaccine. And that goes back to what we talked about earlier with your second dengue infection, maybe more severe than your first, because Dengue doesn't provide good protection against all of the 4 serotypes, particularly in people who've never had dengue. There was outcry in the Philippines when this came out, and it led to a lot of vaccine hesitancy, not just for Dengue in the Philippines, but for all vaccines. And so I think there's still some concern about that risk. The other thing is you have to be tested to see if you've had dengue. So that requires 1, an increased cost, and 2, increased time, because we don't have a test that we can do in your doctor's office, wait 10 minutes, and then vaccinate you. You generally have to come back for another visit. And the third reason is 3 shots given over the course of a year. It doesn't fit well into vaccination schedules, particularly for kids. You know, to bring somebody back 3 times a year for a vaccine is difficult if there aren't other particular healthcare interventions that you're doing at that same time. So there's not been a great appetite for use of this vaccine.
Is there another vaccine in the works that I understand?
So there is another vaccine that has been recommended by the WHO. It's called Dengue. It requires 2 doses to be given over 3 months. So 2 doses, 3 months apart. It also has variable or different efficacy across the 4 serotypes and does not appear to work well against dengue 3 and 4 in people who've never had dengue. It works very well against dengue 2. It works pretty well against dengue 1, but against dengue 3 and 4, it doesn't work in people who haven't had dengue. And unfortunately, the company withdrew their biologic license application to the FDA last year, which means that this won't be licensed in the US because it won't get approval from FDA until they resubmit that biological license application. It's unclear whether or not they will. There was also some indication that there may be also a safety signal with Dengue, particularly for dengue 3 in people who've never had dengue before. There was an excess number of hospitalizations in one country for dengue 3 in people who've never had dengue before. And so there's ongoing studies now to see whether that signal is real. The signal in the phase 3 clinical trial wasn't what we would call statistically significant. It was a trend. So we need more data to see if it's real or not.
I see that Brazil is having a particularly bad outcome.
Yes.
I saw that they're testing out modifying mosquitoes so that they can't get sick.
Yes. There's a couple things. And I should have mentioned when you asked earlier about vaccines, there's also a vaccine that's being produced by a company in Brazil, Institute Butantan. They licensed that vaccine technology from the NIH Institutes of Health. And we tested that vaccine in, I think, about 25 clinical trials here at Hopkins as part of that evaluation process. The Institute Butantan just published their phase 3 clinical trial results of their vaccine, and it looks very good. Now, unfortunately, for that vaccine, it was tested only in Brazil, and dengue 3 and 4 weren't circulating in Brazil at that time. So they don't have efficacy data against dengue 3 and 4, but they have very good efficacy against dengue 1 and 2. So they're working very hard with their regulatory agency to see if they can get that vaccine licensed in Brazil, sort of on an accelerated pathway. So we'll see. Brazil and other countries have tried these modified mosquitoes, and it's really interesting. It's, I think, a fascinating strategy. So what they've done is they've taken a bacteria called Wolbachia, and they've put it into female mosquitoes that transmit dengue. And when these female mosquitoes mate, they can transfer or transmit that bacteria to all of their progeny. And it appears that when mosquitoes are infected with this Wolbachia, that it prevents dengue from growing as well. It doesn't eliminate it from mosquito, but it reduces the amount of dengue, with the thought that that amount can be reduced to a level where it can't be transmitted back to humans. So there was a clinical trial done in Yogyakarta that was, I think the results were released a couple of years ago, that showed that had a very positive impact on the reduction of dengue cases in areas that use these Wolbachia-infected mosquitoes. So that may be a nice, environmentally acceptable manner to vector control for dengue without using pesticides and that sort of thing. So that's a very exciting technology that we're really looking to see if that can make an impact in Brazil and other places.
And so it's not just dengue, really, that we're going to see more of, right? We are seeing a greater trend. I remember there were cases of malaria in the US last year. This seems very concerning. So I'm wondering sort of what your message is to people.
So you're right. I mean, we're seeing a real increase in vector-borne, particularly mosquito-borne diseases like chikungunya. We're expecting that Zika will probably have another outbreak in the upcoming years. We don't know when. We think that some of this has to do with climate change, for sure, making the temperature and everything, expanding the geography where these mosquitoes can really survive. So I think we do have to be really vigilant in that. I will say there's a lot of work now, which I think is very encouraging, on prophylactic and therapeutic drugs and or vaccines for these different mosquito-borne diseases. So there is a vaccine for chikungunya that was just approved by FDA, and recommendations given by the ACIP for travelers, those traveling 18 and older, traveling to areas where there is chikungunya or suspected chikungunya, can be vaccinated. It's a single-dose vaccine, live attenuated vaccine. There's lots of work on dengue antivirals. We're doing some of that work here at Hopkins, testing dengue antivirals in a dengue human challenge model, looking at monoclonal antibodies that can be used both as treatment and prophylaxis if somebody is infected, or, for instance, if there's somebody who can't be vaccinated for different reasons, they can receive a monoclonal antibody and be protected against dengue on their travels. Now, we don't have approval for those yet, but they are in the works. And I think in the future, we're going to have many more tools for both the prevention and the treatment of dengue, and hopefully these other diseases as well. There are people working on, for instance, drugs for chikungunya and vaccines for Zika. We're hoping that the enthusiasm for a Zika vaccine has been diminished over the years as the outbreaks weren't as big as they were in 2015, 2016, but we really do need a Zika vaccine as well. And so we're hopeful that somebody will take up the torch or the baton and work more on a safe and effective Zika vaccine.
Anna Durbin, thanks so much for joining me.
Oh, you're welcome. It's always my pleasure.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Ceciri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ceciri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.